Today's speaker is Amon Asgharpour. So Amon is one of our liver faculty, and he leads a lot of our clinical trials in NASH. And so he's a special interest in NASH. So we're very pleased to have him give us a talk.
Thank you for the introduction.
It's apropos that we have pizza, right?
Yeah, pizza and soda. I need more patience for trials. Guys, eat up. We'll biopsy you, me and the fellows.
Threat then.
No, is that a threat?
Okay.
It's a motivator. So thank you all for coming today. I appreciate you all coming in your busy schedules. I've been given the task to talk to you about non-alcoholic fatty liver disease. Without further ado, here are my conflicts of interest. I've been doing more consulting than I ever expected. There's a quick outline, so we'll start off with definitions so we all know what the heck we're talking about. With NAFAL, and then NASH, we'll talk about disease initiation, predisposition, behavior, the disease impact, why we care, the toll on liver transplant, the rising HCC that we're seeing, the levels, and we have great investigators for HCC here in-house, so they'll cure it soon. Who needs an evaluation? Sorry, supposed to be N, not and. Further analysis through different modalities that we'll go into, and then ultimately with treatments. So let's start off with definitions. So non-alcoholic fatty liver disease is the umbrella. Okay, this is just steatosis seen on either imaging or on histology, so with a biopsy, without significant alcohol use or the use of steatogenic medication. So you got to take a history, okay? Within this umbrella, we have non-alcoholic fatty liver, what's often called simple steatosis in the past. And this is just greater than 5% fat, okay? Without evidence of hepatocellular injury, especially in the form of ballooning. Okay, we'll talk a little bit more about ballooned hepatocytes and how the importance of that has changed over time. We emphasize that a lot more about the ballooned hepatocytes. These are from the latest AASLD guidelines that came out in January of 2018. Then NASH is what we're really worried about, right? So this is that greater than 5% fat with inflammation and hepatocyte injury. So in particular, those ballooned hepatocytes with varying degrees of fibrosis. All right, so let's get to a question. I thought I'd make this a little bit more interactive. So what region has the highest prevalence of NAFAL? Which one? Is it South America? Is it right here in the good old North America? Is it Middle East, Asia, Africa, or Europe?
Asia.
You can go live there. I ain't living there. Middle East. It's actually, Middle East was the number one. We look at UNASI's paper, followed by South America, and we're kind of in the average 24% there. Okay. So this is just a pictorial to show you, what a normal liver looks like up at 12 o'clock. At 3 o'clock, we have a fatty liver, and that affects 25 to 30% of the population, depending where you are, as I just showed you. And then we have that more aggressive, the steatohepatitis, the NASH, okay? It's about 6% of the U.S. population. And unfortunately, as you guys know, this can progress to cirrhosis and necessitate a liver transplant. And unfortunately, it can happen all over, where you have the post-transplant patient, their NASH gets worse. Unfortunately, there's medications that drive this, and they may even need another liver transplant. We see that sometimes. And these patients are all at increased risk of a cardiovascular death, right? Liver death, and then cancers. And we'll go into this a lot more. So to help understand, this gestalt, to help come up with a language to talk about what we're seeing on liver biopsy, Kleiner out of the NASH Clinical Research Network, the CRN, he's at the NIH, came up with the NAFAL activity score. Okay, and it has 3 components. That's steatosis, graded from 0 to 3. That's just depending on the percentage they saw in high power field. Let's see. So here we have large droplet steatosis, macrovesicular steatosis that pushes that nucleus to the edge right there, okay? It's full of triglycerides. Then inflammation is how much lobular inflammation the pathologist sees on high power field. And ballooning is that really important feature I talked to you about earlier. It's graded from 0 to 2, so none, few, and many. It's quite subjective by the pathologist. In dead center, you have a ballooned hepatocyte, okay? Some of the characteristics that we're looking at here are the scalloped edges, okay? And then you see this ropey eosinophilic inclusions. One of my fellows want to call out what the heck that is? Not to put you on the spot, but I'm putting you on the spot. What is it? Yeah, Mallory Dankbody. Yeah, yell it out, you know. Okay. So those are actually cytokeratin. Okay, so the structure has been altered, and all that cytokeratin gets deposited here. All right, and these evade apoptotic pathways, and they actually drive disease state. And we found out over the years they're really important. They're more important than we initially thought. And even Kleiner gave a talk at ASLD back in 2015, suggesting that we expand this score from 0 to 5 because it's that important. Really hasn't caught much traction though. And furthermore, you know, so it's such a silly name, non-alcoholic steatohepatitis. So you would think there's fat and inflammation, this must be NASH, right? That's not the case. You have to have ballooned hepatocytes. So Pierre Bedossa, who was crucial for the Medivir analysis and was a pathologist out of France, helped come up with this algorithm with the FLIP consortium, as he called it, to help other pathologists who weren't as familiar with NASH biopsies, to help them understand the difference between steatosis and NASH. And you just need greater than 5% to get in the spectrum, right? So some fat. Our latest faculty member, hello. So we have to have some ballooning. So you have to have at least 1 or 2 in ballooning, and you have to have at least some inflammation to call this NASH instead of just steatosis, okay? So disease initiation. So there are genetic predispositions one can have, okay? The most characterized is the PNPLA3 mutation, and Helen Hobbs found this. So she was looking at the Dallas Heart Study data from GWAS and found this gene, okay? And they didn't really know what it did at first, but it's important for fat mobilization, okay? So if you have this gene mutation, you're at increased risk. If you have these mutations, it just lowers your threshold, okay? We know there's lots of PNPLA3 mutations, especially in our patients from Mexico and our Hispanic patients. So that's why we see that disparity amongst our populations. And TM6SF2, transmembrane 6, superfamily 2, is also has to do with lipid transport. So these people have trouble mobilizing fat, and that's what puts them at risk. One of our newer faculty, Nora, put this paper out in New England Journal in April of last year, where they did more GWAS analysis. They actually found HSD17B13 as a protective loss of function variant. This is actually a gain of function, the PNPLA3 mutation, and this is a loss of function mutation. And if you have this loss of function mutation, it actually protects you. So it helps you just have that steatosis without the steatohepatitis for both alcohol and non-alcoholic fatty liver disease, okay? And they're working on kind of utilizing this, leveraging this for therapeutics. They're working on knockouts therapeutics, okay, siRNA, but that's far from for prime time. But again, these just lower your threshold. But really, it's the disease initiator. It's the adiposity. It's the behavior. It's eating way too much pizza and soda. It's drugs too. So like amiodarone, TPN. So when we're consulted for elevated LFTs, oftentimes we think about a cholestatic picture with TPN, but it can cause a fatty liver. Okay, so just be aware of that. You don't see this much adrenal ileal bypass. That's probably related to the diversion of bile acids. Other genetic disorders, especially with lipids, people with familial hypertriglyceridemia can be at risk for fatty liver and systemic inflammation. But it's really behavior. It's really behavior that drives this.
Can I just add?
Please.
These loci are overlap with alcohol-related liver disease.
Absolutely, absolutely. And to your point, I think I mentioned it. Yeah, and we see that with our Hispanic patients too. A lot of our patients who are coming in with ALCHEP and alcoholic-related liver disease and who are cirrhotic and Hispanic tend to be a little younger, is what I've noticed, especially here at Sinai, more so than when I was in Richmond. But yeah, there's definitely an overlap and a lot of commonalities. And we see our patients who, we joke around and we say BASH, right? Because they're drinking and they're overweight and they have type 2 diabetes. They have both of these drivers because they're common loci.
Amon, are you familiar with commercializing some of these assays to be able to do genetic testing? I know that they're available, but not easily done here.
Yeah, they're not really done too much. And then, it's like if you get it, what do you do about it is the question. You're still going to recommend the same lifestyle modifications for that person.
Like really don't have a little early again.
Yeah.
You're able to catch it early
Yeah.
stages.
And they're not all going to get it either. So that's the problem with it too, right? They may get it, they may not. So I think there's always like the double-edged sword of doing genetic testing and the 23andMe stuff, right? I'm sure you get messages all the time in my chart like, I did 23andMe and I found this. Like, what does it mean? And then you have to go look it up, and it doesn't mean much. So it's something to consider. I think we're doing it more for clinical trials than anything else, but it's definitely something to consider down the road. I know Naga was mentioning they do it. They do it in their lab for their patients to try to counsel them that way. But it's something we should potentially think about.
Well, we've got whole exome sequencing on 2,500 patients already. All you have to do is ask for it.
For those patients, exactly.
Yeah, for ones that are in the lab.
But it's really about the increase. So again, it's about the behavior. It's obesity. It's a sedentary lifestyle that's really driving this disease state. You really need to engage the patients as to why they're having trouble to adhering to this. One of the things that I learned early on is, sometimes this is their coping mechanism is eating. So you really need to ask them about that. Think about referring them to a clinical psychiatrist. We tend as hepatologists to ask those hard questions about drug abuse. But we have to also think about sexual abuse in these patients as well. Is this one of the reasons why they're having obesity is because they have an underlying psychological issue that we need to unravel. But as I mentioned, it's mainly behavior. So I don't know if you guys have seen these New York Department of Health advertisements on TV. This campaign started in January of this year, where they're comparing high fructose corn syrup to smoking and obesity, and they even tried to tax it, right? Not too long ago to try to discourage that use. And when we're seeing high fructose corn syrup really driving this disease state in a lot of the animal models that we use, and that's the first thing I ask the patients to cut out is these empty calories, especially the sodas and the juice. People still have that false belief that juice is healthy for you. So you really need to go over that with your patients when you're giving them some counseling. And this is some of the latest data about obesity around the world. So we're not the most obese country anymore. Kuwait actually overtook us in a lot of the Middle East. But the world population is 7.5 billion, and almost 8 people in the world are living with obesity. So this is a growing problem. And this just kind of is a flow diagram of what's occurring. So you have that genetic predisposition, like we talked about those mutations earlier. Then you have the disease initiation, which is typically the behavior, which leads to a phenotype. And there's perpetuating mechanisms, so mainly the behavior. We know that the gut microbiome is likely playing a role here, especially with LPS and toll-like receptor 4 and inflammatory pathways there. Metabolic issues, apoptotic and fibrotic pathways are also leading this perpetuating mechanism of disease. But luckily, there's restorative mechanisms. The liver is very forgiving. So there's stem cell activation, regeneration, cell matrix crosstalk, improvements in the microcirculation, and metabolic reprogram that can reverse this disease. And so ultimately, it's this balance for our patient to see, are they staying the same? Are they getting worse? Are they actually getting better? And we'll go through ways we can make. So some common conditions associated with NASH are obesity, type 2 diabetes, dyslipidemia, the metabolic syndrome, and polycystic ovarian syndrome. So this is really the liver manifestation of the metabolic syndrome. And some other conditions that are associated but not as strongly linked are hyperthyroidism, obstructive sleep apnea, typically with obesity there, hypogonadism, hypopituitarism, psoriasis, and pancreatoduodenal resection. And actually, we were just recently talking with the chairman of dermatology about some of his psoriasis patients. So what's the impact of this disease? Why do we care about this disease state? It's a little older slide now. Probably the last time I'll show it. This is one of my co-fellows. She did this study and looked at the 2015 registry for liver transplant patients. And so here in New York State, it's law to check patients born between 1945 and 1965 for hepatitis C, which is at the highest risk of hepatitis C in that cohort, right? We call it the birth cohort. What's that?
Under the under 30 crowd.
Oh yeah, well, with the opioid crisis, yeah. So she looked at in 2015 for the patients registered who were under 50. So in 2015, all those people were over 50, right? So if you were born in 1965, it's when you turn 50. And she found that there was actually more NASH patients registered then, and fewer Hep C. And you can see the trend that changed there. And this is actually reality now. We know that now. So this paper came out late 2018. This is Mazan's paper, and it shows that actually for men who got liver transplanted, the number one reason was alcohol, and red is number 2, and that's NASH. But in women, NASH already took over for transplant in our country. So we've been talking about the takeover forever, but it's actually already started. And then the national trends and rates of new cancer cases, you can see for both men and women, liver cancer is number 1. Okay, so not only is it the rates are the greatest, but the death rates are the greatest. So it's happening more commonly, and people are dying from this. Okay, it was number 2 for men in trends in cancer death rates, and number 1 for women. So question number 2. All the following are part of the initial diagnostic workup for NAFAL to accept: history to rule out significant alcohol consumption and steatogenic medications, liver biopsy, iron studies, viral workup, or autoimmune hepatitis workup. What do you guys think? What don't you really do at that first visit? Nobody wants to speak up. So as Doug says, you don't do liver biopsies on the first date. Bring them back. Do some more investigation. Do your ultrasounds. Do your other stuff first. But these are things we have to think about. Okay. I love blaming all these racy things on you. So who's at risk?
He's thinking them anyway.
Yeah. So patients with liver elevated chemistries are at risk, and this is the ACG guidelines now. Okay, and they say the upper limit of normal for men is really in that range from like 30 to 32, and women is like 19 to 23. So it's really much lower than a lot of the electronic health records. For Epic, we go up to 45. ECW, which we're not using anymore on the west side, went up to 70. So a lot of the providers were just missing this because the patients had like 75, 80, and they're like, it's not that high. But it was like 4 times the upper limit of normal for a woman. In addition, they mentioned, if there's steatosis on imaging and the abnormal liver chemistries, the likelihood of NASH is much higher. So really, that should clue you in that this patient might have a more aggressive form of this disease state. And this is the laundry list workup we do for elevation of elevated liver chemistries. So number 1, as we mentioned, you got to take that history for alcohol use and to see if there are any of these common medications that cause steatosis, such as methotrexate, tamoxifen, steroids, and amiodarone. And I check the Hep A status just because I'm gonna probably vaccinate them. I don't think, I really don't check for acute when they're coming to see me. Their LFTs shouldn't be that high. Hep B status to vaccinate them. Remember to get that core to see if they were exposed. The Hep C status, and so on and so forth. We don't do this for everybody where I'm, checking autoimmune hepatitis, but if their numbers are high enough and they're at risk, is something I think about. And then liver ultrasounds, other routine tests, including basic labs for MELD, and then other imaging modalities and other workup that we'll go into further. But you really need to do this. I had a patient who had 4 different liver diseases, and I never would have known unless I checked all this stuff. So I really urge you guys to do it. This is a diagnosis of exclusion until you get the biopsy. So these are things you have to. What's that?
Whatever happened to
Yeah, not everybody's liver reads that one, unfortunately. So we have the elevated LFTs we got to think of, and then fatty liver on imaging. Oftentimes it's incidental that the patient went to the ED or had abdominal pain and they got some kind of scan that showed steatosis. So I'll see these patients in my clinic quite often. And then you have to ask yourself, do they have abnormal liver chemistries? And if they do, you have to work them up, such as NAFAL. If they don't, then do they have features of the metabolic syndrome? Then you should work them up as NAFAL. If they don't, then you need to ask them about alcohol or medications. And just remember, patients with NASH can have normal LFTs, okay, all along, and even progressive cirrhosis with normal LFTs. So something for you to think of.
Amon, can you comment on patients who have a pretty good profile that fits NASH, yet an outside ultrasound, which they walk in with, does not show steatosis?
I find sometimes they won't say it in the bottom, like in the impression. So I always find myself going to read the findings part to see if they mention echogenic liver. And you're right, sometimes on the outside they don't call it, and then I'll repeat it here. My default is when I do an ultrasound here, I'll always ask them I'll type in, please use Doppler and comment on spleen size in our patients. And more often than not here, they will catch it. If you have those rare cases where they don't really call it, and we need to think about other causes of liver disease, or even think about doing liver biopsy, which may show it. But usually it does show up in ultrasound, which is the nice thing.
Would a high CAP score help you?
Yeah, it can be dubious sometimes. So sometimes you'll see this disconnect where you have, steatosis on imaging, but the CAP is on the lower side. But by the guidelines, the imaging should trump. But then sometimes you have the opposite, where you have the high CAP and they're not really calling it on imaging, but everything else fits the bill. In my mind, that is probably a NASH patient. And depending on what that kilopascal score is, I'll think about doing a biopsy on them. So patients with type 2 diabetes, so we talked about elevated LFTs, we talked about steatosis on imaging. In particular, patients with type 2 diabetes, we have to be very careful. They're at high risk for NASH, okay? And they need to be, so the ASLD guidelines say they need to be risk stratified to understand how much scarring is in their liver. So to understand the degree of fibrosis. And they endorse using NAFAL fibrosis score, FIB4 score, or the VCTE, vibration control transient elastography. That's our Fiberscan. Okay, and we're going to go into all of those in detail. And they also mentioned that MRE and Fiberscan are great tools to understand the degree of fibrosis on the and also give you like a numerical value.
So Fiberscan bridge to Epic is supposed to be activated this summer, so that data will electronically come in and be searchable into Epic like endoscopy reports. But they'll also have searchable. Those aren't searchable, but these will be searchable. It'll have the numbers, so we should be able to do a database search and these numbers.
So that way you don't have to hunt in the media tab for the Fiberscan, which can be quite painful. So that's a nice thing that Doug's been championing for a while. So actually the American Diabetes Association just put out guidelines this year echoing what ASLD said. So now we have some guidance for the endocrinologists. Some of the non-believers I have to believe now because it's in their guidelines. And I'll tell you, I gave a lecture to the New York Society for Clinical Endocrinologists in May, and most of them were shocked to see these new guidelines and hear about NASH. And the big ADA meeting, they're really pushing this. They had quite a few speakers talking about NASH. And they kind of echo the same thing, that these patients with type 2 diabetes, elevated liver enzymes are at increased risk for NASH and cirrhosis. They even talk about referring to a hepatologist and considering liver biopsy. So it's nice to have other societies kind of on board now and thinking about the liver.
Although they're not going as far as advocating screening.
Well, yeah, they're just saying to have it on your mind and to consider using non-invasive tools such as elastography and fibrosis biomarkers, but they're not giving like the strict kind of like use NAFAL fibrosis score, etc. But they're leaning heavily on the ASLD. Yeah, at least they mentioned us. So the fibrosis matters. So I wanted to talk to you guys a little bit about fibrosis before we delve into this too much. So I put two different kinds of stains here. This is a serious red. This is a trichrome. We tend to see more trichromes clinically here in the US. And it's F0 to F4. So F0 is no fibrosis. F1 is the sinusoidal fibrosis, okay? So I want especially our fellows to pay attention here. This blue is what's staining all the collagen and the fibrosis. So you can see it's like this chicken wire pattern, and it's around the actual hepatocytes. That's what we're talking about. So you hear pericellular or sinusoidal fibrosis, they're the same. Okay, that's what we're talking about. Then F2 is sinusoidal plus periportal. F3 is still bridging, and F4 is still cirrhosis. I'm a big fan of the serious red, and I know a lot of the labs, you guys do it a lot in the labs. That just stains the collagen red. The nice part about that is you can put it into a computer, and they can measure the collagen proportional area for you to give you kind of a numerical value. So it's not as subjective and give you more objective data. And I mentioned it, fibrosis matters because it influences survival. Okay, we know that over time, our patients with F4 and F3 disease, they die. Okay, so it's really important to watch these people and help prevent this progression and understand where your patient is on the spectrum of fibrosis. The prevalence study was a really nice study done by Dr. Angula, and he was trying to look at all these different histological features, other parameters to understand kind of what was important, what led to death or liver transplant in our patients over time. Some of these people were followed out to 30 years, and it was a good cohort from all over the world, from North America, South America, Asia, etc. And what they found was, out of all those things I told you, ballooning, inflammation, steatosis, the fibrosis is what really mattered, okay? And the greater the degree of fibrosis, the higher the hazard ratio for death or liver transplantation, okay? Age also came out. Diabetes and smoking were also related to death or liver transplant. The only thing that was protective was statin use, okay? So if you guys ever come with me in clinic, I will calculate AHA scores on my NASH patients myself. I will see if they need a statin, and I will order them a statin, because nobody else tends to. Like, the endocrinologist gets scared too, the primary care gets scared when they see these elevated LFTs. This is Haki Min's paper. He was one of my mentors at BCU, and he actually described this. He's a basic scientist, and he showed that there was more shunting towards free cholesterol, increased HMG-CoA reductase in these patients. That's where our statins are inhibiting, right? That increased free cholesterol is in the circulation. These patients actually have decreased LDL receptor on their liver. So more of that fat is staying in their circulation and ultimately leading to atherosclerosis and strokes and heart attacks, okay? So I mentioned to you guys earlier, these patients are increased risk of strokes and heart attacks. So we need to start them on statins. And there's even mentions in our guidelines for portal hypertensive GI bleeding that statins may have an antifibrotic property as well. That's still not totally teased out. So how do we...
Quick question.
Yes, sir.
Some of the studies for cirrhosis in general have shown that coffee drinking is protective. I can't remember whether that's been looked at specifically in the NASH cohort.
Well, they talk about in the big review article for coffee. They talk that it is preventing steatosis in general too. So it seems like it does help. It's, I'm always telling my patients don't. The one thing I tell them is do drink coffee. It's always nice to give a positive spin on our patients. So I encourage them all to drink. And the study is caffeinated coffee, 2 to 3 8-ounce cups a day. Okay, so just, it's nice to tell patients, oh, you're drinking coffee, that's a great thing, instead of no. I don't like to take the paternalistic approach towards patients. But it was shown to prevent cancer, fibrosis, and steatosis, if I recall, with coffee.
Question on that prior table, was that hazard ratio, was that liver-related mortality or no?
Yeah, death or liver transplant.
Okay. All-cause mortality for death?
It was all
Trying
cause.
to corroborate it, this is cardiac related.
Yeah, it's cardiac.
Okay.
It's cardiac, exactly. So how do you evaluate? So there's a lot of scoring systems out there. This is just a few. There's even some called like HAIR and a bunch of other things that are out there. But the ASLD really just endorses the NAFAL fibrosis score and the FIB-4 score. Okay. Carissa, thank you for the slide. I have a mention for you at the end. She hooked me up with a bunch of slides. So NAFAL fibrosis score, you can go online and use a calculator. I just put a really, common patient here so you guys can see how we do this. So the age, 62-year-old, BMI 33. Check the patient has diabetes. AST is 30, ALT is 60. So you guys know that's elevated. Should be 30 for a guy and 20 for a female. Platelets at 175, lower end of normal. Albumin, this is the caveat if you use this. It's in grams per liter, not in grams per deciliter. So a 3.4 turns into a 34. And the score here is 0.827. If you look, that actually predicts the presence of a significant fibrosis. So this patient is at risk, even though these labs are so common. The FIB-4 score, so initially developed by Richard Sterling for HIV Hep C co-infection, okay? And it's just part of the Apricot trial, I believe, right, Doug?
Yes.
Apricot, yeah. So it uses, very simple parameters. There's no Boolean like yes, no for diabetes, so it's a little easier to implement into electronic health records, and that's something that we're working to do here at Mount Sinai. And you can see the age 65, AST is 45 in this patient, ALT is 30. When we see that flip over, that gets me worried about cirrhosis, when AST gets greater than ALT in these kinds of patients. Platelets on the lower side at 150 gives you a score of 3.56, and that's a likelihood to have advanced fibrosis greater than 2.67. So the cutoffs you'll see online are 1.45 and 3.25. Those are for co-infection, Hep C, HIV. You need to use these lower cutoffs for NASH, okay? So just be mindful of that if you want to use that calculator. But we're hepatologists and we have Fiberscans. So typically this is what we're going to use. Most of you all have seen this in our clinics, but it's a nice tool that just kind of taps them over the liver, sends a sound wave. If you remember in physics, the harder something is, the quicker the sound wave travels. So the harder the liver is, the quicker the sound wave will travel, and it'll give us a higher score. So it gives us two components, the liver stiffness measurement, which is fibrosis in kilopascals, and the controlled attenuation parameter, the CAP score, which is steatosis in decibels per meter. We have different probes. So we have an M probe, which looks at a segment that's 4 centimeters long, from 2.5 to 6.5 centimeters from the skin, and a deeper one for our thicker patients, the XL probe. And then they keep telling us the XXL probe is coming out. It's supposed to come out this year, but I haven't heard about it yet. We'll see if it comes.
We should have the pediatric probe shortly in this month for August. Anyway, we're hoping as well.
Is that one going to do CAP? Because it didn't used to. It doesn't really do it.
I'm not sure. I don't think it does actually.
And at what age do they recommend conversion from pediatric to adult?
Depends on the size.
Yeah.
The ones that Jamie Chu's been sending upstairs.
They're mediums.
200 pounders.
Yeah.
So then,
They're
that's not a
adults.
problem.
Yeah, they're adults. And the software will actually cue you. So if you try to use an M probe, it'll say at the bottom, use the XL probe, because it's not appropriate. So I imagine it'll be the same with the S probe, the small probe. And this is just to remind everybody using the Fiberscan, the values vary depending on disease state. We know that livers with HIV tend to be a lot stiffer. And then the numbers for NASH are on the higher side compared to Hep C, so something to be mindful of, okay? And then this is probably the nicest study that I've seen looking at the CAP and CAP cutoffs. It was a French study where they had a bunch of diabetics who were going to get liver biopsies. They marked the spot they were going to do. They actually did a FibroScan, marked the spot, they did the liver biopsy the same day in the same area. Compare them. And they found some different cutoffs here. I'll put like the practical cutoffs from the study that we're using here at Sinai. So greater than 240, greater than 270, and greater than 300 for the different degrees of steatosis. But it's not perfect by no means. And as we were mentioning earlier when Gene was asking the question, sometimes you'll have a disconnect between the ultrasound and the Fiberscan. Typically, the ultrasound will trump the Fiberscan about calling steatosis or not, because that's what the guideline says. So MRI, proton density fat fraction, and MRE, MR elastography are other useful modalities that we have, and we're lucky at Sinai we have 4 of these machines at our disposal to use. The PDFF, I found out used to take 6 seconds, now it takes 4. It's really quick when they're getting an MRI. So if you're sending a patient for any MRI for any reason, and you were concerned about the degree of steatosis, just write in the comment, please do PDFF. It's very easy for them to do. The MR elastography, so instead of like one spot of tapping with the Fiberscan, it's a gigantic paddle that goes over their liver. It kind of buzzes their liver and does the same thing by sending that sound wave through them. And then this just to show you, so this is steatosis across here. You can see how pale the liver looks when there's 23% steatosis and some kind of intermediate points. The one caveat about the MRE, the kilopascals are different, and it has to do with the Young's modulus. I am not a physics expert to tell you the formulas there, but 3.6 kind of relates to the 10 kilopascals that we see on the Fiberscan. So that's when we worried about F3. So 10 on a Fiberscan, 3.6 on an MR elastography. Those are kind of the magic numbers to remember. And this was a nice study done by Rohit Lumba's group in San Diego. So they went to a diabetes clinic and they grabbed the first 100 patients, none of them known to have liver disease. They offered them MRI PDFF and MR elastography. 98 of the 100 actually showed up for the imaging study, which is really good. And 65% had greater than 5% fat. So 65% of these people had fatty liver disease and didn't even know about it, okay? The scarier part is 7 of those 98 had F3 or above and didn't know about it. Okay, so this is why we recommend looking at our diabetic patients and evaluating them because they're at that increased risk for NASH. But there's still a role for liver biopsy. As you guys know, we do lots of liver biopsies here, but not as many with the Fiberscan. We don't really need to biopsy Hep C like we used to. But this helps us assess the prognosis, to stage the fibrosis, and to consider initiation for drug therapy, for clinical trials. You kind of get a 2-for-1. Understand what's going on with that biopsy, and then submit it for a clinical trial. And then rule out other causes of liver disease, because sometimes we don't know, especially with autoimmune and with overlap syndromes. We don't know, you have to biopsy. And this is kind of like an algorithm that Mary Ranella and Arun Sanyal came up with. And I pretty much follow this loosely. So you have the steatosis on the imaging and elevated LFTs. You've eliminated alcohol and other causes of liver disease, confirmed NAFAL. Then you have these low-risk patients who are younger, their BMIs are on the lower side. And just be mindful, guys, we're in New York. Our Asian patients, the BMI cutoff for overweight and obesity is much lower. It's 25, okay? So be mindful. I've been sent patients who, their Asian BMI is 27, and when before I meet them, I ask, is this patient overweight? And the provider says, no, they're not overweight. And I see their BMI is 27. Like, they're overweight. They probably have NASH. We biopsy them, they're NASH. So be mindful, guys. Patients who don't have other features of metabolic syndrome and had low scores, these aren't people I'm rushing to biopsy. I'm just going to keep an eye on them. Probably will reevaluate them in 6 months to a year, consider Fiberscan at that time just to keep a close eye. And then you gotta have people in the middle ranges, with everything, they have risk factors. It looks like they might have F2, F3. These are people we really need to consider doing a liver biopsy on to understand the truth. These scoring systems, even the Fiberscan, they aren't that great in the middle. They're not that great for F2, F3. So these are people you need to consider biopsying. And then we have our cirrhotic, our patients who probably have cirrhosis that, we'll consider biopsying or MRE for trials. You don't always need to biopsy these patients either, but it's something you have to consider. So let's get to another question. So once a patient is diagnosed with NASH and advanced fibrosis, treatment options include metformin, as it's been shown to effectively treat NASH and diabetes, education about weight loss with diet and exercise, ursodeoxycholic acid, 13 to 15 milligrams per kilogram per day, urso greater than 28, or liraglutide, as it's shown to reverse fibrosis but has no impact on other features of NASH. What do you guys think? B. Yeah, that's the answer. We have we'll talk about treatment, so weight loss and pharmacological therapies. No surprise, there's no FDA-approved drug as of yet, right? This is something I discuss with all my patients to help motivate them. There's a multitude of studies to show that weight loss with diet and exercise can reverse this steatosis, even resolve NASH, and regress fibrosis, okay? So I break it down with them, so 10% weight loss. If a patient weighs 200 pounds, it's 20 pounds they need to lose over a year. Like, doc, I can't lose 20 pounds, it's too much. Well, it's less than 2 pounds a month. Seems a lot more tangible when I say it that way. And work on their caloric restriction to achieve this goal. The best study out of these randomized studies was the Villar Gomez paper out of Cuba. And all he asked these people to do was to walk a little bit more and to cut their calories by 300 to 500 calories a day. And many of them could achieve that weight loss goal. So this is something you really need to break down, talk to them about it. This is where I counsel them to cut out the juice, cut out the soda, try to get an understanding of your caloric intake. I think a lot of people don't understand where their calories are even coming from. I tell everybody to take a picture with your phone. Everything that goes in your mouth, you take a picture, and then calculate your calories at the end of the day, and then work on reducing them. That insight is crucial. So I'm sure a lot of our clinicians have seen these morbidly obese patients, and they're like, "Doc, I don't eat anything." And then once you get them to keep their log, you realize what they're really eating. And they really start to realize what they're eating, because a lot of them have no clue. So the current status of pharmacological therapies, as I mentioned, there's no FDA-approved drug. There are drugs that are available, but they have issues, and they're not approved for NASH, including vitamin E, pioglitazone, and liraglutide. There's more limited data with obeticholic acid and elafibranor, and we have clinical trials here. So I'll go through these. I'll try to go quickly because I have a few more slides and we're starting to run out of time. So the pivens trial, so this was Sanyal's paper that came out in the New England Journal, put out by the NASH Clinical Research Network. So there was no pharmaceutical company involved, and they looked at non-diabetics. Okay, that's kind of the key role here. They looked at pioglitazone, vitamin E, and placebo. The caveat here is with the vitamin E, they use a very specific type of vitamin E. They use the Nutrimate formulation, which is RRR alpha tocopherol. Okay, if you go to the vitamin store and look at vitamin E, it's all these mixed tocopherols, so it's really hard to endorse anything like that. And also in a diabetic patient to really endorse using vitamin E. So just be mindful. I know some providers kind of throw vitamin E on everybody, nobody here that I know of, but in other institutions. You need to be mindful about just starting people on vitamin E, because it's not without risk.
You tell them about a specific brand or provider?
Pardon me?
Vitamin E.
So Nutrimate was the one that was actually studied, but I tend not to endorse vitamin E. So there was a paper that just recently came out looking at the haptoglobin genotype, and actually gave that oral presentation a few years ago at ASLD, and we found so vitamin E is an antioxidant. Patients who have a haptoglobin mutation, such as or genotype 1, 2, or 2, 2, if they have that 2 allele, they have really bulky haptoglobin. So 1, 1 is a dimer, and it can scavenge all that loose heme to prevent oxidative stress. But when they're like 1, 2, and 2, 2, they have these huge polymers that have trouble scavenging. So that's one of the thought processes, is that if you have that 1, 2, or 2, 2, the bulky haptoglobin, that you actually will benefit from vitamin E. So we did that study, and we recently published that paper. But that's not something that's commercially available. It's something you have to do in your lab to understand that, and then see if they would benefit from this type of vitamin E. It's harder and harder to find the Nutrimate version of vitamin E. And
Nutrimate or Naturemate?
I think you're right. I think it's Naturemate. I have to go back and look, but it's a very specific form.
It's Naturemate.
Is it Naturemate? Yeah.
What is the data on the cardiomyopathy and death from vitamin E? There was some reports.
Yeah, so that's the problem. Like I mentioned, they're available, but they have problems. And you can see, so some of the highlights from the study I want to talk to you guys about. So there was overall histological improvement compared to placebo with vitamin E and pioglitazone, but we had this high placebo effect. We see this in all the trials, like 10 to 20% response in our placebos. Resolution of definite NASH was greater in vitamin E and pioglitazone. And there was even, if you look at absence of ballooning on central review, it was 28% in pioglitazone, 18% in vitamin E, and 17% in placebo. I didn't put that on this data or on this slide, but as Benna mentioned, there's problems. So vitamin E, long-term safety issues of prostate cancers in men, all-cause mortality, and hemorrhagic strokes. So not as appealing as it used to be. Pioglitazone, issues with osteopenia, heart failure, and weight gain. We used to think there was an increased risk of bladder cancer, but that's been teased out, and that's not the case, is what the current data is showing us. And Ken Kuzi is a big user of the TZDs down in Florida, and he'll really push for them. Liraglutide is one of our GLP-1 analogs that's gained a lot of traction. It's being studied in further studies now with semaglutide, the once-weekly injection. But this was the lean trial out of the UK. And one other thing is the time frames are starting to decrease. So the pivens trial was 96 weeks, and here we're at with the lean trial at 48 weeks. And you'll see with the trials the numbers are coming down. And this was a very small study, 23 and 22 in each arm. And it did look like there was some NASH resolution and improvements in ballooning. So the reason this was wrong in the question I asked, I said it improved fibrosis. It didn't help with fibrosis, okay? But it does help with ballooning. So maybe in conjunction with other drugs. And we know that GLP-1s really help with weight loss, okay? So that's probably the effect that we're seeing is this weight loss effect. I'm starting to run a little low on time, so I'm going to go quicker. FXR has a multitude of actions, but it's end product. So this is the farnesenoid X receptor. This is a receptor for bile acids, okay? And what happens here is that ultimately it decreases plasma triglycerides and free fatty acids, improves triglyceride clearance, and unfortunately can cause plasma HDL decreases. So that's the good cholesterol, if you guys remember. So this is one of the first big studies that came out. This was the Flint trial that was done by the Nash Clinical Research Network, the phase 2b trial, looking at a beta-cholic acid, which is a potent FXR agonist. So your endogenous agonist is quinodeoxycholic acid, one of your primary bile acids. And this has 40 to 100 times the affinity. Okay, and it's a nuclear receptor. And so in this trial, so this was the second one that came out. So the first one was pivens, 96 weeks. Then this is 72 weeks. We're already starting to drop that endpoint in time. And what they did is they gave a beta-cholic acid at 25 milligrams PO a day, and they gave placebo in patients with NASH. And they found the primary endpoint in this study was improvements in NAFAL activity score of greater than 2 points without worsening of fibrosis. They also looked at improvements in fibrosis. And you can see with a beta-cholic acid compared to placebo, there was a p-value that was significant in this trial, the phase 2 trial. The downside was there was pruritus that was dose-dependent, decreases in HDL and increases in LDL. I was a sub-I for this trial, and when we did it, you could tell who was on drug because, I don't know what happened there, okay. You could tell who was on the drug because their LDLs all went up. And then we just started them on statins. And I don't have a problem with that because I showed you earlier the statins are protective on these patients. Unfortunately, the phase 3 trial, the Regenerate trial, the data just came out earlier this year, and they kind of lost that NASH resolution effect that we were so happy about. They also looked at different doses to kind of get rid of those side effects of pruritus, so 25, 10, and placebo. The NASH resolution fell out. It wasn't there, but there was an improvement in fibrosis. Okay, so it seems like it's more of an anti-fibrotic compound than a NASH resolution compound. So maybe this drug in conjunction with like a GLP-1 or something along those lines may be beneficial down the road. So PPARs, these are common drugs that have been looked at for fatty liver, and TZDs or PPAR gamma activators. So and they work on insulin sensitization, lipid metabolism, etc. They have those problems that we talked about. PPAR alpha, so just fenofibrate, helps with decreasing triglycerides and has positive effects, as does PPAR delta, with increasing of the HDL, and it also induces hepatic fatty acid beta oxidation and with lipogenesis in general. Okay, they did the Golden trial, which was the phase 2 trial with elafibranor. This is Genfit's compound, to understand if there would be a role here. So they did this for 52 weeks, the phase 2 trial. And it was the first time I read this, I was like so confused when I read this paper for the first time, because in the middle of it, they changed the endpoint, the updated definition of the protocol endpoints. So the primary endpoint was resolution of NASH without worsening of fibrosis. And protocol defined is that absence of at least 1 steatosis, ballooning, or liver inflammation. And number 2, no worsening of fibrosis. Okay. Then later they changed it to be a little bit more stringent, with disappearance of ballooning and overall pathological diagnosis of steatosis alone. So that resolution of NASH. Okay. It was really weird that they did this, and it made no sense to me at first. And I had to read it and like think about the context of the timing. I mentioned to you guys earlier that over time we realized how important ballooning was, and not these other kind of features, the steatosis, the inflammation. So just having resolution of inflammation is not resolution of NASH. You have to have that resolution of ballooning. So this table is really funny the way they did it. So here you have the protocol-defined primary outcome, the total patients, the breakdown of NAFAL activity score greater than 3, and those with NAFAL activity score of 3, so milder disease. And so you can see the N, and the N is the same for the modified definition. And then they tell you the response rates. Okay, that's what's in parentheses, and these are how many patients were really in the study. And you can see, like, if with the original definition, 50% of the placebo had a response here. Okay, with that original definition. When they made it more stringent and used the ballooning disappearance, they got rid of a lot of that noise from placebo. Okay, so that's when it started to make sense to me that that's why they're doing this. But it's still kind of funny science, right? Changing your hypothesis in the middle of your experiment. And that's when they saw some improvement here in a good odds ratio. But elafibranor at 80 milligrams kind of fell out. 120 was more favorable. So it took me a while to really understand what was going on here. And what they, kind of the take-home messages are that it really is a NASH resolution drug. Okay, it doesn't really have much improvement for fibrosis. And there's actually cardiovascular improvements in these patients as well. It decreased their cardiovascular risks and it was well tolerated. So they've moved on to the phase 3 trial, which we're running here as well with Genfit. This is a super busy slide. I apologize for that, but this is just to show you that chemokine ligand 2 is important for from stellate cells and monocyte activation and ultimately fibrosis. Okay, and this is the cenicrivirox study. So this is the dual CCR2, so chemokine receptor 2 and 5 antagonist that was done at 52 weeks. And this was actually the first study. So when you look at it, it doesn't really look like it helps with NASH at all, right? Because the placebo is at 6% and the cenicrivirox was at 8%. Well, this was actually the first study to show that you could have improvements in fibrosis without resolution of NASH, okay, an anti-fibrotic drug. And Regenerate was kind of the second to show that with the beta-cholic acid. And then there was another definition of resolution of NASH with no worsening of fibrosis and improvement in fibrosis by at least one stage with no worsening of steatohepatitis. It was 10% in placebo and 18% in the cenicrivirox study. And we're doing the phase 3 study of that currently. And this is just to show you that there's a ton of clinical trials out there, and that we have several ongoing trials here. We're actively recruiting F2 to F4, and we have more NASH trials coming online. So Catherine was kind enough to make this slide to show you some of the studies we have. So we're still doing the Regenerate study and enrolling patients in that. That's our F3 obeticholic acid study.
The action just closed.
When did we close? We just closed?
Yeah.
Oh, wow. Okay, never mind. I'll put X's on that. That one closed. The Allergan trial is still enrolling. That's our other phase 3. That's a cenicrivirox molecule. Genfit, we're still enrolling. That's the other phase 3.
It's not Allergan anymore, it's AbbVie.
Now it's AbbVie, yeah, right? It was
It's
Tobira, then Allergan, now AbbVie. And then the other phase 3 study, which I didn't have time to go into, was the selonsertib, the ASK1 inhibitor study with Gilead, and it actually seems to be a negative study. They put stuff out there about it not really working as an antifibrotic. But we also have, I didn't have time to go into the BMS study, but this is a recombinant FGF21 sub-Q weekly injection that shows improvements in LFTs and steatosis quite quickly based on imaging, and we're doing the study to see if it holds up on biopsy. There's even another F2, F3 study, NGM, which for those who were here when Eugenia gave that talk a couple months ago, is a daily injection, and also looks like it's decreasing LFTs and decreasing steatosis in a matter of months, 2 or 3 months. So another very promising drug. And then we have the Madrigal study that should be open in another month or 2, hopefully. And they're going to actually take F1s in that study. So if you have some F1 patients, we will have F1 studies available for them. And then we have a couple way down the pike, Celgene and the Eli Lilly compound. So stay tuned for those. We just closed our BMS F4 trial a couple weeks ago, so we're not taking patients for that one anymore. And then we have the Intercept reverse trial, so beta-cholic acid for our cirrhotics, which at first was a little scary to think about because of all those poor outcomes in our PBC patients. So we're watching these patients like hawks, like a hawk when we give them the obeticholic acid. So I think I just barely finished in time, so thank you all for bearing with me. I want to give a particular shout out to Meredith and Shanti, who are crucial in our CTO department and help run all these clinical trials. Please feel free to email them, email myself. This is where we do our trials, where the fellows do their clinics. And a special thanks to Arun Sanyal and Krista Chang for hooking me up with slides. And I always have to thank my wife for putting up with me. And thank you guys. Any questions I can answer?
So how about metformin? You mentioned it in one of your slides.
It doesn't really help with NASH. I mean, it helps with diabetes. I like that it's weight neutral for the most part. So if a patient who has like NASH and F2 and has diabetes and the diabetologist reaches out to me about starting metformin, I'm okay with it. Like the TZDs cause weight gain, so they're not really as exciting. But we want to control their diabetes. It's crucial too. But it doesn't have a specific role on its own for NASH.
Curious about HCC NASH. When do you start putting your NASH in terms of fibrosis into high risk group for HCC?
Yeah, so I actually took the slide out to the one you're probably alluding to from the El Sirag study from Houston, which was very provocative when it first came out, mentioning that there's a lot of HCC in patients without advanced fibrosis, right? We don't see as much of that clinically as they described, and they even had a follow-up paper to show that it wasn't cost-effective, right? Because I just told you 25% of Americans have this. We cannot do HCC screening on 25% of Americans for 6 months. We'll make the whole healthcare system, broke. But our F3, F4s, these are people I'm doing it on. I try to get away with ultrasounds, but sometimes they're just so obese that you need to think about doing other modalities. We do have an abbreviated MRI clinical trial that's being run here. It's like a very short MRI with a lower dose contrast to look for HCC. So there are further things along the way. I typically am just doing it to the cirrhotics or the people who are borderline F3, F4. I think about in some cases I'll do some of the F3s, especially if they have like strong family histories. I'm worried about it. That's a great question.
Other questions? Yes.
Please.
You said you put your patient on statin very easily. Would you do that with all NAFAL patients or according to the cholesterol level?
So when do I start the statin?
Yes.
So I do a risk. There's a risk calculator through the American Heart Association that I use, and I'll just put all their blood pressure, their hypertension, diabetes, smoking history, and race, and then it'll tell me their risks, and then I'll start from there. And what I personally do is I write it in my note what the score was, and I mention that I'm starting the statin, and I'll send a note to the primary care doctor and the endocrinologist that I'm starting this, so that they don't get scared and feel like they have to be in charge of this, and also so they don't stop it. Because the older guidance used to be when you started a statin to check the hepatic profile later, and if it's elevated to consider stopping this. But we know that it's quite safe and it's beneficial. And a lot of the times it's that process of adaptation that's occurring in the liver, and that you'll see those numbers normalize later. So as long as it's not getting too high, I don't worry much about it.
So just to comment that, although it's not recommended in screening guidelines, the odds ratio or the hazard ratio for HCC in patients who are homozygous PNPLA3 is about 12. So if I knew that, I wouldn't necessarily genotype them, but if I knew that a patient, or if they were Hispanic, where the prevalence is higher, and I knew they were PNPLA3 positive, I probably would
consider it,
earlier than if they weren't.
And in those cases, you might be lucky enough that there is that disconnect in body habitus and their NASH, where they may be this thinner NASH kind of patient, and we may be able to get away with ultrasound on some of those patients. And that's something I always think about, is if I have like a lean NASH patient, they probably have a genetic mutation. I actually wasn't aware of that, so thank you for that. Yeah, so that's an important. I always get a little bit worried about these lean NASH patients. Luckily, we don't have a whole ton of them.
Yeah, oddly enough, though, for the PNPLA3, the risk of NASH, and I don't know. So first of all, it's not very prevalent in Asians, but it only confers a risk of NASH once they're obese, which is interesting. So if they're lean PNPLA3 positive,
Maybe they
it's
have
not
a
clear
yeah.
that they're at the same risk. It's when obesity is present. That's been true for a lot of the genetic causes.
Yeah, it definitely lowers your threshold. But I've always been curious, like, when you have these lean NASH patients, is it a PNPLA3 plus a T6 or transmembrane 6 superfamily 2? Do they have both? Is there just other gene loci we just don't know about? But I'm always a little bit more worried about those
Well, if you
folks.
talk to the metabolic experts like Jerry Schulman, what they'll tell you is that it's exactly the same disease as in obese NASH, but at a much lower set point. So everything that you said, now why is that? I don't know.
Yeah, why the threshold is low. Yeah, it may just be the mobilization of lipids in general, and just the way they're kind of the lipid metabolism.
Actually, we just transplanted a patient of mine with BMI 24.
With NASH.
With
With
NASH.
NASH, salvation,
Yeah.
with diabetes.
Yeah, with Dr. Chowdhury from Calcutta, he gave a nice talk at EASL in like 2014 describing NASH specifically in patients from India, starting at BMIs of 23. So that's something I want, especially the fellows, to be tuned in about our Asian patients, including our Indian patients or Middle Eastern patients, that they may not fit the typical bill.
I want to end here.
I'm
Thanks.
sorry. Thanks.